All right, so my name is Dhalston Cage. I am a physical therapist here at the Andrews Institute with Children's Health, and we're going to be going through some return to play considerations for the ACL athletes going forward. So looking at some objectives, wanting to be able to review current concepts related to general ACL rehab and the timelines associated with proper recovery and return to sport. Wanting to be able to formulate general guidelines for proper stepwise progression based on objective and subjective information that we get from our patients. Being able to understand various objective measures that are helpful when determining proper return to play for the ACL athlete. And then wanting to be able to utilize current evidence to support post-op ACL rehab as well as return to play decisions. So kind of moving forward, we'll get into a little bit of a background, looking at just the numbers and prevalence of ACL injuries, going back, looking at research dating back just even a few decades ago, roughly 80 to 250,000 ACL injuries per year, with roughly just over 100,000 of those actually turning into ACL reconstructions or going through surgery that are performed annually. 70% of all ACL injuries tend to be non-contact, and then the remaining 30% of those are of the contact variety. And then looking at just like a disparity between male and female athletes, there's a snippet here from some research that was done that showed girls and women are experiencing these injuries at roughly 3 to 6 times the rate of boys and men. Contact injuries tend to be higher in our male athletes, while the non-contact injuries tend to be higher in our female athletes, as well as ACL graft ruptures and contralateral ACL tears are 2.7 times higher in adolescents than in adults. So for our patient population here at Andrews, we're obviously seeing a higher rate of female athletes being injured with ACLs, as well as our specific patient population looking at the youth athlete. So looking at a mechanism of injury. So as we kind of talked about that non-contact mechanism, how does that happen? There's a short video here that we're going to use to help us describe that mechanism. It's going to give us a brief anatomy overview. It's going to allow us to see, as we see our femur, our tibia, and our ACL. Our ACL is used to limit anterior translation of our tibia as well as rotation. As you can see the anatomy here. And then it's going to move into looking at how this non-contact mechanism tends to happen. We have an internal rotation of the hip, an external rotation of the tibia, and then pronation of the foot, which can oftentimes, as we suspect, lead to our non-contact ACL injury typically seen during like deceleration movements, pivoting movements, cutting. A lot of times you'll have athletes or patients tell you that they were just turning to run a different way. They were cutting, they were coming to a stop after sprinting, they felt a pop, and there went their ACL. So obviously a ton of research is done looking at how do we prevent this? How do we decrease the chances of this? And that's still up for debate. But as we move forward, we can talk about the research and rehab considerations for our patients as they go through post-op. So specifically talking about prevalence across sport, looking at our female athletes specifically here on our chart. This is going to show us that we've got women's soccer, women's lacrosse, women's gymnastics, and women's basketball that tend to be the highest prevalence. In terms of specifically sport, when we see these ACL injuries, with men's football and then men's lacrosse coming up here just below them. And so we can already see that there's a disparity between men and women, right? But we can also see that in terms of prevalence, we can see that soccer, lacrosse, gymnastics, and basketball for our female athletes tend to be the most common. Then we can also compare them across gender. So again, we kind of saw this in the previous slide, but we can see that women are dominating this aspect. Our female athletes are definitely more prevalent than our male athletes. With men's football is also up here as well. But again, kind of like we've already briefly talked about, our female athletes are suffering these injuries at a higher rate. And then specifically looking at their sports, basketball, soccer, gymnastics, and lacrosse tend to be the most common for those female athletes. And so now we're going to move into just some general rehab principles, talking about different aspects of rehab in terms of immediate, maybe even prehab considerations, post-op considerations, and then different milestones and objective data points that we like to take and use as we progress our patients through their rehab timeline and prepare them to get back to their sport. So this was a graphic taken from a recent clinical practice guideline that was just came out earlier this year. It was out of the Aspetar group, which is out of the Middle East. And basically, I felt like this was a really good representation of how ACL rehab tends to go, talking about from the early stages onto the later stages and into return to sport. So early on for our athletes, we're spending a lot of time focusing on their knees specifically, looking at reducing pain and swelling, looking at just improving their range of motion, and then improving their strength overall. So a lot of time just focused specifically on the knee itself. As we go through the early phases into the mid stages of rehab, we tend to focus more on functional movements, such as walking or squatting, and then talking about improving their overall strength, their overall cardiovascular fitness, and then improving at the end point of their mental readiness or their psychological readiness when it comes to getting them back to their sport. So it's a moving continuum where we focus on the knee specifically early on, and then as we continue on later into their rehab, we're talking about more functional movements. We're focusing on the person as a whole, and getting them psychologically ready to return to whatever sport, whatever activity, whatever movements they did to initially injure themselves, getting them prepared to complete those movements, those tasks, or compete at that same level, and have them be confident that they can do that on their involved limb. So this was a chart taken from another recent study that was just published earlier this year as well. And this, I felt, did a really good job of outlining just criteria that are important for our youth athletes when it comes to preparing themselves for surgery, right? So there are definitely, kind of think of these as almost like some like non-negotiables in terms of what we would like to see prior to them going into surgery to help prepare them post-op to have the best outcomes. So looking at trace to no effusion, having full range of motion, particularly focusing on extension. They talked about having a minor flexion loss is okay. Hopefully with being within 95% of the uninvolved side, or at least getting to 120 degrees of their knee flexion range of motion. Having minimal to no pain, so scoring a 2 out of 10 on their pain rating scale. And then moving into more functional signs, having the ability to control their lower limb alignment during functional tasks. So this can be squatting, single leg squatting, stepping up to a step, stepping down from a step. So having the ability to control that involved limb during those different functional tasks. Having good quadriceps function, which they defined as a straight leg raise without any sort of quad lag, and the ability to control the knee during gait and single leg stance. And then having normal gait, so good quad function leads to our ability to ambulate and walk normally. So having normal gait without crutches, without any sort of aid. And then psychologically, this is obviously a really big component. It can be tough to prepare, a 13, 14, 15, 16, 17-year-old for surgery, especially ACL surgery. And so just having the ability to go through this prehab process is really beneficial for us as therapists, but also for our patients and our athletes to, one, build that connection for them, helpfully answer any questions that they have and prepare them for not only surgery itself, but obviously immediately post-op for surgery, outlining expectations, outlining home exercise programs for them so that they can have the best outcomes moving forward as they get ready for their long journey through rehab. So now we're looking at our post-operative phases, and we're going to go through a few different phases. We're going to outline some goals for each phase, and then we're going to get into some research that supports and backs some of these phases as well. And so looking at our post-op phase 1, this is typically looking at immediately post-op to about 2 to 3 weeks post-op. And our goals here are outlined as having an emphasis on full passive extension. We're going to hear that a lot throughout this presentation. And that's just going to allow us to really set us up in terms of having a normalized gait pattern, being able to achieve good quad function, and then allow us to get into more functional activities earlier and more efficiently. Again, focusing on having a control on post-operative pain and swelling, looking at getting and achieving range of motion between 0 to 90 degrees is optimal for us. Depending on if there are any additional injuries to the meniscus or other ligaments, that range of motion can be altered. But 0 to 90 degrees is a really nice goal for the first couple of weeks, just to kind of get that knee moving as we start decreasing swelling. Then again, looking at early progressive weight bearing. This is going to be huge for us if we don't have any sort of like meniscal injuries, having the ability to just stand or even practice like some weight shifting side to side, or even taking a few like early steps. Early weight bearing is going to be really beneficial for our patients as they prepare for moving forward into more functional tasks. So weight bearing is going to allow us to limit the amount of atrophy that we see, and it's going to prevent actually our quad inhibition, which is really important. So having the ability to weight bear early, having the ability to have a good quad function early on, is going to set them up really well as they kind of transition through this early to mid phase of rehab. And then probably the most important piece for immediately post-op is having good independence in their home exercise program. So being able to outline various exercises or stretches or mobility things that you want them to work on, outlining, the importance of elevation and ice, outlining the importance of how often they're doing their exercises, what's the point of their exercises, and then being able to have them kind of reiterate that back to you, just so that you're on the same page, where we can really drive home and improve outcomes early on, and set you up really nicely as you continue to move forward through your earlier stages of your post-op rehab. And so this is another piece from that Aspetar group that talked about early rehab considerations. And so again, just to reiterate, having active knee motion should begin immediately after surgery, being mindful of any surgical instruction like meniscus injuries. And they found that immobilization actually does not decrease pain and can lead to muscle atrophy, which overall can slow recovery of function. Early weight bearing within the first week should be done in a progressive controlled manner, as tolerated by each patient, and then again being mindful of any other surgical instructions as well. But again, just to emphasize, having early active knee motion is going to be incredibly beneficial for our patients and important. And then also, if we're able to weight bear early on, the earlier the better for our patients. That's going to set them up really nicely moving forward. So now we're looking at our second post-op phase. We're kind of transitioning out of those first couple weeks, looking out towards the 6-week mark. Goals for us here, again, working on making sure that we're achieving that full knee extension, so that's 0 degrees, and then even pushing forward towards 130 degrees, which is nearing normal knee flexion range of motion. Being able to achieve that within the first 6 weeks is incredibly beneficial and huge for our patients. And then again, it's just going to set them up really nicely moving forward. Looking at our patellar mobility, so making sure that we not only touch on this, but it should be kind of more of a focus for our patients. Being able to not only us as therapists working on their patellar mobs with them, but also teaching our patients how to properly do this themselves at home. This is just going to really help with decreasing the formation of like arthrofibrosis, any sort of scarring after that can lead to, pain and dysfunction of our quad, and limit our ability to get into deep flexion range of motion. So good patellar mobility is going to be a really big point of our rehab, and I think sometimes this part is overlooked. So focusing on that early on as well, continuing to decrease and minimize swelling, restoring normal gait. Want to be able to get out of that kind of common limp that we see, making it less and less antalgic and more normalized. And then also being able to focus on ascending an 8-inch stair. So trying to work on going up a step with good control and without pain is another part of our goals here for this first kind of continuing to work through this early phase of rehab. And then looking at specifically range of motion, this was a study done back in 2008 that was a nice long-term study that focused on roughly, it was a 10-year follow-up and looked at over 500 patients. And essentially they went through and just looked at how does range of motion loss affect these patients long-term. And they defined normal knee motions, but specifically extension, as being within 2 degrees of extension, which also included hyperextension as well. So as you can see, kind of with these red outlines, we've got our extension outline, we've got our flexion outlined as well. Normal extension being within 2 of the other knee, nearly normal extension being 3 to 5 degrees within that contralateral side, abnormal being within 6 to 10 degrees, and then being severely abnormal being greater than 10 degrees, so having greater than 10 degree extension loss. And then flexion, similar, being within 5 degrees is deemed normal, 6 to 15 degrees is nearly normal, 16 to 25 is abnormal, and then greater than 25 is severely abnormal. So they went through and they focused on these patients in terms of long-term. They followed up with them at 2, 5, and 10 years. And we can kind of see these are outlined here. This top chart is focused on flexion, bottom chart focused on extension. And essentially what they found was roughly 16 to 17% of all patients had nearly normal or abnormal knee flexion range of motion at 2, 5, and 10 years. So essentially they fell outside of that 5 degree window in terms of their knee flexion loss. And then roughly 14 to 15% of all patients had nearly normal or abnormal knee extension range of motion at 2, 5, and 10 years. So they fell outside of that 2 degree knee extension loss window. And then they also looked at how did this affect these patients. So what they found was just a 3 to 5 degree loss of extension, including loss of hyperextension, indicated altered subjective and objective results after knee surgery. So we can see in this chart here, we've got this top line, which is going to outline normal knee extension and flexion. This is going to give us our greatest scores. And then these bottom 3 lines are highlighted down here, whether it's a loss of flexion, a loss of extension, or a loss of both, are showing a significant decrease in their scoring overall. And that's looking at even up to 18 years post-op. So it's just incredibly important for us to focus on our knee range of motion, especially extension, early on in order to achieve that. So then looking at another study that focused on our knee range of motion, specifically looking at knee extension range of motion at 4 weeks and how it relates to knee extension range of motion at 12 weeks. And this study found that Obtaining normal knee extension range of motion, so being within that 3 to 5 degree window of the uninvolved knee at 4 weeks, so being nearly normal, may be used as a clinically significant predictor of normal knee extension range, which is being within that 2 degree window at 12 weeks. So if we can get our patients to as close as normal as possible, being within 3 to 5 degrees of the opposite side by the 4 week mark, that is predictive of having normal knee range of motion at 12 weeks, which is our ultimate goal. So ultimately, get the knee as straight as possible, as early as possible. So now we're going to kind of move into our post-op phase 3. And this is going to really focus on becoming more and more functional, right? Where you're kind of moving away, kind of remembering that early chart of focusing a lot on the knee itself. Now we're kind of transitioning a little more into more functional tasks for our athletes, for our patients. And this is kind of transitioning us from that like 6 week mark to roughly the 14 week mark. So pushing us around that 3 month mark. And goals for us here, again, focusing on restoring full range of motion. So not only being able to demonstrate the ability to go up a step or ascend a step, but actually be able to go down and have good eccentric control as we descend a step with good leg control and without pain, ideally. Being able to improve ADL endurance. So being able to not only help our patients as they are transitioning back into just going to school normally, they're walking around school normally, hopefully. They are going to extracurricular activities outside of school, whether it be church or going to practices with their siblings or helping out parents around the house, doing chores, whatever it may be. Being able to improve our patients' ability to complete those just normal daily tasks and have the endurance to do so. Again, looking at improving and focusing on our lower extremity flexibility and mobility. And then another important piece, as we start to do more, we want to be able to protect that patellofemoral joint. This is why it's important, one, for us to achieve really nice range of motion, but have a nice balance of the amount of activity and exercises that we are doing in order to protect our knee. A lot of times patients will start to do too much, or they haven't achieved the really basic milestones as they continue to increase their just level of activity. And that can cause a knee or a patellofemoral joint that gets really kind of painful, and it can set us back big time in terms of rehab. So finding a good balance so that we can continue to push them forward, but we also want to make sure that we are protecting that patellofemoral joint throughout our phases of rehab as well. So this was another really nice study that was just published just over a month ago, I believe. And they did a really good job of highlighting and just kind of outlining really basic criteria for ACL patients post-op that would allow them to be successful as they transition from the early stages of rehab to the mid stages of rehab. So during this part of rehab that we're talking about right now. And we can see here, we can kind of think of these first few as like your non-negotiables, right? So what things are super important for you as a therapist or as a clinician, and how do these things affect your patients as we move forward? So these outcome measures are highlighted here on the left, and then we've got how we would test them, the goals for these, and then the reasoning behind them. So we're just going to look at these outcome measures, and then we're going to look at the goals for these, and we'll kind of talk about each kind of testing things that are relevant for each one. So first being pain. So having knee specific pain being within that 0 to 2 range, and then having a tolerance to higher pain as we do more, keeping that pain level before 4 or below 4, sorry. In a non-specific area may be acceptable. So again, just controlling pain is a really important part as we start to do more and more. Swelling, so having 0 to trace swelling, we can kind of see how we would classify that. 0 being on your kind of stroke test, having no wave produced on your downstroke would be 0. And then trace, having a small wave on the medial side with your downstroke. And then you can see 1+, 2+, and 3+ there. So that would just be, an increased amount of swelling that would not fall into those categories of 0 or trace. Here we are again with passive knee extension. So achieving a straight knee, having 0 degrees of knee extension, being able to not only having 0 degrees, but seeing a way where the patient is improving and making progress to the point where they can achieve full knee extension compared to the other side by the end of the mid-stage of rehab. And this can be variable. There's different research out there that will talk about, if you have too much hyperextension, we really want all that hyperextension. But keeping this, not talking about outliers, but keeping this kind of more in a normalized or controlled manner, wanting a straight knee, obviously, and then barring any sort of like crazy hyperextension, we want to be able to achieve normal knee range of motion as close as normal to the other side as well, just to help with just normal functional tasks. You have one knee operating with one certain range of motion, you want the other knee to operate with the same amount of range. And then again, similar passive knee flexion, they kind of categorize that as having at least 120 degrees of knee flexion. More than that is just icing on the cake, but 120 degrees being the cutoff point for this phase of rehab. And then having really great quadricep recruitment. So having the ability to sufficiently recruit the quad with no quad lag on a single straight leg raise through 10 reps. So being able to straighten your leg out completely, have good quad control, raise that leg up 10 times and not have any sort of increased bend in that knee is going to show us that we've got good quad activation, we have good control, which is going to allow us to continue to kind of push forward in our functional activities through our rehab process. And then lastly, for our non-negotiables, we've got walking gait. So being able to just sufficiently walk, having a normalized gait without any sort of aid or help. So that can be crutches or a walker or whatever your patient is using in the early stages of rehab. We have since moved on from that. That can also include our knee braces. As we've moved into this later kind of mid-stage of rehab, we want to be able to just have a normal gait, have patients being able to walk around their homes without any issue, being able to go to school without any issue, and just walk normally in order to just live kind of a normal life at this point with just normal daily activities. Having an abnormal gait pattern can be associated with joint weakness and low patient satisfaction scores, decreased functional performance, and then can actually lead to post-operative complications within like early onset osteoarthritis. So normalizing gait, that's what we do most as humans. We're doing that, hundreds of thousands of times a day. So that's a lot of stress. If we don't have a normal gait pattern, we can alter kind of stress patterns or stress forces onto our knee. So making that as normal as possible is going to help us out a lot. And then these next few are kind of categorized as nice to haves, but these aren't kind of the end all be all for transitioning to the mid stage of rehab. So movement quality, and they kind of quantify this as having the ability to squat to 90 degrees with appropriate kinematic alignment, and having sufficient loading symmetry between limbs. So if you have access to like force plates, you're actually able to like objectively assess their squat pattern. This is categorized as having less than 20% asymmetry between limbs is having sufficient loading. So being 80% or greater in your limb symmetry in terms of your squat pattern is what they show to have good movement quality. And then again, looking at knee extensor strength. So there's limited research. You're going to have different people who will say, 60%, 70% at this point, even upwards of 80% sometimes. But based on their findings, they suggest a limb symmetry index of greater than 60%. And this is done through isometric testing with a maximal voluntary contraction of the knee extensors or the quadriceps at 60 degrees and 90 degrees, which was done through 4 reps of 3 to 5 seconds with 1 minute rest between each set. And typical knee extensor deficits can range from 40 to 60% at the 4 to 6 week mark, and that can kind of even linger on as we move into the 8 weeks, or even up to 12 weeks typically. But the greater the extent of our knee extensor deficits, the harder it is to regain that knee extensor strength as we continue through rehab. So that's just a really big emphasis for the early part of our rehab plan. And then lastly, very, very similar for knee flexor strength, or for our hamstrings. Again, they suggest a limb symmetry index of greater than 60%. And this is again done through isometric testing, the same protocol as the knee extensors. Okay, so now we're moving into post-op phase 4. So this is kind of more of the fun stuff. We're getting a lot more functional. We're going to look at possibly looking at running soon. So goals for this is demonstrating the ability to run pain-free. We want to continue to maximize strength and flexibility and mobility to meet the demands of just daily living as well. But also we're starting to specify a little bit. We want to look at what are things that our athletes or our patients are going to have to do as they return back to their respective sports too. And then isokinetic testing, they have it set as 85% limb symmetry. So we're looking at weeks 14 to 22. This is, 3 to 5 month mark, even closer to 5 to 6 months or so. So 85% limb symmetry, in my opinion, is probably a little optimistic, especially we do a lot of quad tendons here. So those numbers are probably going to be a little less at this point, but they have it set at 85%. And I think the big takeaway from this is that regardless of what the number is, there should be some sort of set criteria or some sort of data point that we should be looking at so that we know that our patients are strong enough, whether it's 75% symmetry or 70 or 65 or 85 or 80. We want to have those data points set. We want to have that criteria set so we know when our patients are ready to progress to their next phase of rehab. And so talking about running, how do we know when our patients are ready to run? I know a lot of old kind of research will talk about, just getting to that 12-week mark, get them to 3 months, and we can start some kind of early running stuff. And a lot of times that may not be the case just based on patient progression through their early phase of rehab. We can't always predict how someone's knee gets straight earlier than others. If their knee flexion comes back great, if their quad comes back great, how the quad tendon graft is going to affect their overall function of their quad. So going based off time is kind of tough. We definitely want to look at time. We definitely want to wait a set amount of time. We can set a minimum for that. But we also want to use a criterion-based approach as well to go along with our timelines to give our patients the best chance of returning back to running safely and without pain. So 2 studies done here that kind of pulled together some really good information on when they felt it was okay for patients to return to running. And they deemed these as just kind of 8 different points. And the first being having 95% knee flexion range of motion. So essentially nearly normal knee flexion range, having full knee extension range of motion as well. Having no effusion or trace effusion. So all of these are starting to sound really familiar, right? We want to focus on having normal knee range, having minimal to no swelling. And then they also looked at their limb symmetry index as being greater than 80% for quad strength before you return to running. This may not be the case. There's some research out there that will show 70% as your cutoff point or 65%. But for this one, they've got 80%. They also looked at limb symmetry index for the counter movement jump. So they were looking at that being greater than 80% during the eccentric impulse during counter movement jump. So having the ability to absorb force at 80% of the rate of the uninvolved side, right? So as we step off of a box height and we go down into a counter movement jump, being able to absorb that force, having good eccentric control is going to essentially translate over into running or jogging, which is essentially just a series of like single leg jumps over and over and over again. If we don't have really good eccentric control, we don't have good ability to absorb that force, we can cause a lot of stress and a lot of specifically joint stress at the patellofemoral joint, which can lead to just an increase in knee pain, which can turn into just lingering issues for us as we move through our rehab timeline. So that's why it's so important for us to have the ability to not only have the strength, but the ability to use that strength and absorb those forces as we work on jumping and running. Going through pain-free, whether it's aqua or water jogging, or using the Alter-G, which we have the benefit of using here. Pain-free repeated single leg hopping or pogos. And then it's one thing to be symmetrical, right? So having the ability to say that my uninvolved limb and my involved side are 80% symmetrical or 90% or 70%. That's important, but it's also important to note that having the ability to produce force as it relates to your body weight and having that also be enough is important as well. So if the cutoff value that they found, and they're looking at quad strength to body weight. So how strong am I, specifically my quads, compared to how much I weigh? For initiating jogging was 1.5 or 1.45 Newton meters per kilogram. So essentially being able to produce, 1.45 Newton meters of force as it relates to how much I weigh in kilograms. There's also differing research on this, 1.45, 1.6, 1.7. Again, just to kind of reiterate the fact that it's kind of all over the place. Anywhere between this 1.45 mark to 1.6, 1.7 tends to be like that normal window to start jogging. But also just to mark that how important it is to just have some sort of objective data point that we can look at and say, hey, my athlete is strong enough, my patient is strong enough, I feel good about them starting to practice jogging, starting to practice jumping, so that I know I'm not going to cause any sort of increased knee pain that we shouldn't have to do, especially early on in our rehab process. So now we're looking at post-op phase 5. So this is going to be that 5-month mark as it kind of just transitions to 6, 7, 8, 9 months as we look at returning back to sport, or even upwards of a year, or even beyond a year. Everybody's different. And they have their goals here that are outlined, or having a lack of apprehension with sport-specific movements, being able to maximize strength and flexibility to meet the demand of the individual's sport, isokinetic testing greater than 90% limb symmetry, hop testing greater than 90% limb symmetry, and then not only it's one thing to have objective, but also do our athletes pass the eye test? So having an acceptable quality of movement assessment. How do they look as they squat? How do they look as they jump? How do they look as they land? How do they look as they change direction? How do they look as they sprint and decelerate? So a lot of different aspects that go into that in terms of movement assessment. So now we're going to look specifically at return to sport guidelines, and what specific criteria we like to assess in order to get our athletes back on the field or on the court or back to their respective sports, and things that we like to take into account to make sure that we can make them as prepared as possible so they can have a safe return back to their sport. All right, so we're going to focus here on return to sport guidelines, which we want to focus on as we look to transition our patients back to their respective sports. looking at different guidelines and metrics that are going to help us best prepare our patients and feel good about them getting back to their sports and hopefully reducing their risk of re-injury moving forward. So this was a study that was published just a couple of years ago, and they looked at different kind of rehab milestones, and they had their own kind of return to sport guideline. But one of the pieces that I took from this was specifically looking at return to sport in terms of what timeline, what does that look like for our athletes? And they found that the Delaware Oslo ACL cohort study actually found that there was a 51% reduction in re-injury rate for each month return to sport was delayed up to 9 months. Furthermore, another study looked at and found that there was a 7 times increased risk of new ACL injury for athletes returning to sport prior to 9 months. So 9 months looks to be the minimum cutoff point for getting our patients back to their sport. Going back before then, you can essentially take it as like a flip of the coin, whether you're going to re-tear, and that's just based on data and research that has been done. And then waiting till 9 months reduces your risk significantly. And then even waiting beyond 9 months looks to continue to decrease your risk of re-tear. So 9 months, again, for our patients is the minimum timeline that we like to wait for when it comes to getting back to sport. Are there going to be instances where a patient is really pushing for is their senior season, or they're playing in college and they want to get back earlier? Sure. And each patient's situation is different. But for most patients, we want to wait till 9 months at the minimum. And then even beyond that to help prepare them to really get back and feel comfortable and confident in their sport. So even upwards of 12 months or even beyond that is completely normal. Some considerations to look at when it comes to returning our patients back to their sports. There's different criteria like we've talked about already. We'll kind of go through those here. So no pain or swelling. Again, full knee range of motion, having a stable knee, so whether that's assessed through like a pivot shift or a Lockman or anterior drawer, or even in instrumented laxity evaluation tool to help us get a really good idea of how that ACL graft is doing, and how kind of healthy it is and how strong it is at this point of the rehab. Having a normalized subjective knee function, which is categorized as being greater than 90%, in terms of the patient's ability to just state that their knee feels normal, but also psychological readiness using different patient-reported outcome measures. We typically use the ACL RSI, or the ACL Return to Sport After Injury Scale, but also the IKDC, or the International Knee Documentation Committee, and there's also a pediatric version of that one as well that we use here. And sometimes you can also see the Tampa scale used as well. But having some sort of subjective and psychological component, it's one thing to have objective data and make sure that your patients are strong enough and they're able to perform tasks, but having the ability to assess their own psychological readiness and how they perceive themselves in terms of being ready to go back to their sport is another really important aspect of their return to sport process. So looking at their strength specifically, isokinetic quad and hamstring strength, or peak torque at 60 degrees per second. We want that to be greater than 90%, ideally even greater than 95%. Symmetry for return to high demand pivoting sports. And then counter movement jump and drop jump having a greater than 90% symmetry in terms of jump height, as well as concentric and eccentric impulse. So having the ability to not only absorb force and at a rate that is 90% similar to the other side, but also produce force at a rate that is 90% symmetrical to the non-involved limb. And then also, this is kind of getting into the weeds a little bit, but having a reactive strength index of greater than 1.3 for double leg, and then 0.5 for single leg. Movements in terms of being able to produce the amount of force, getting jump height, and then taking that over the amount of time it takes to get to that jump height or produce that height. So how reactive are our patients at this point? And this is important for especially our field sport athletes and also some of our court athletes like volleyball and basketball athletes as well, when it comes to stopping and producing force and jumping. Jumping biomechanics, so being able to normalize absolute and symmetry values for moments, angles, and work in both vertical and horizontal jumps, especially in the sagittal and frontal plane at the hip, knee, and ankle. So not only can we produce force at a normalized rate, but what does that look like? Does it look normal, or are we compensating with different kind of movement strategies on our involved limb? And then running mechanics, restoring greater than 90% symmetry of vertical ground reaction forces and knee biomechanics during your stance phase, as well as during high-speed running and change of direction. So if you have a way to, we don't really have a great way of here ourselves of quantifying that, but if you do have a way to do that, then that's another great way to just assess your patient's ability to run normal again. There's some other research out there that will look at, do patients ever really get back to normal running post-op ACL? And some would say no, but if we can restore that to greater than 90%, then that gives us a really good just indication that rehab has gone well in terms of being able to just run and achieve high speed running as well as change of direction. Have your patients completed a sport-specific training program? Thankfully, here we have access to Exos, which does a great job for our athletes, transitioning them out of just specific rehab to becoming and treating them more of like a global athlete as we prepare them for just sport-specific tasks and movements and training, again, their whole body all over again. So that is a huge benefit for us here. But another important aspect of returning patients back to sport, going just through like typical PT rehab for X amount of time and never getting into really sport-specific movements or training doesn't really translate well to your athletes getting back to sport confidently and comfortably whenever that time frame is. Rehab process, we talked about this just a little earlier, but greater than 9 months, anything before that is just an increased risk that I don't think is necessary. So achieving that 9-month mark or even beyond that is going to be very beneficial for our athletes. Single leg hop symmetry, both vertical and horizontal, greater than 90%. And then they found, we talked about peak torque to a body weight earlier, but they found that an isokinetic relative strength cutoff value, specifically talking about peak torque to body weight of greater than 3 Newton meters per kilogram, may be a more sensitive predictor of good patient-reported knee function in recreational athletes than just symmetry alone. So of course, we want our limbs to be symmetrical. We also want to make sure that both sides are strong enough to again support our body weight as we're sprinting and decelerating and cutting and jumping and single leg hopping, right? So it's one thing to be a 200-pound linebacker. You've got symmetrical, non-involved side and involved side, great. But are we producing force even on both limbs that is strong enough to support our body weight through these dynamic movements? So that's another really important part of the rehab process to get an athlete fully back. So these next few slides are just kind of talking about quad strength overall and what those look like at 3, 6, and 9 months, and just normative values based on not only gender, but graft type as well. And so when we're looking at this, we can see here that, for example, our graft types are kind of outlined over here on the left side. And we've got our timeline up at the top. We've got 3 months, we've got 6 months, and we've got 9 months. So I've highlighted here our quad limb symmetry index normative values at each time point for each graft. So if we want to look at this bottom percentage number here, this is going to be for quad tendons, which is what we see a lot of here. And they found that at the 3-month mark, normative values for our quad tendons are typically 52%. Normative values at 6 months are typically 67%. And then normative values at 9 months are typically 77%. So again, this can change based on graft type, but just specifically talking about quad tendons, because that's what we do see a lot of here. Normal symmetry index, normal LSIs for 9 months look to be around that, upper 70% range. So if we want to be able to get them back to sport at 9 months, but we also want, we just talked about having a 90% limb symmetry index to get them back to sport. So that's why timelines can just vary, right? We want to make sure that we have a minimum time frame for our athletes, but we also want to make sure that we have minimal objective criteria for our athletes as well, so that we can put both of those together, which will ultimately provide them with the best outcomes as they get back to their sport. And this is a recent study that we are actually hoping to be a part of as it moves forward, but this is very specific to our patient population. This is a group out of Virginia that is looking at the University of Virginia, that is looking at over 700 patients, and I think they've even grown more and more since then. But they published on this one specifically looking at roughly 783 patients at the 5 to 7 month time frame, and they were able to basically give normative data as well. They've got a really nice dashboard online, but what that was actually pretty similar to what we just talked about in the previous slide. But what I took from this, from their paper, was that the average participant in our study exceeded common recommendations for functional readiness for return to sport based on their single hop for distance as well as triple hop. But when you take those numbers, so symmetrically, they were greater than 90%. But when you take those metrics and you compare them to their peers based on age and sex, those values could actually place them only as high as around 50th to 60th percentile, or even as low as the 30th and 40th percentiles among their peers. And then similar findings were found for both the involved limb as well as the uninvolved side, for physical function and strength. So all that to say, when we're at this kind of 5 to 7 month mark and we're transitioning and pushing on forward to return to play, our athletes may be symmetrical, but we also have to take into consideration that the uninvolved limb is probably also atrophied and deconditioned as well. So comparing our involved side to our uninvolved side can get a little muddy when we're looking at limb symmetry alone. So we want to be able to find other metrics like peak torque to body weight, or having other functional measures that we can use to make sure that our patients are ready as we get them back to their sport. And then lastly here, this was a table pulled out of a recent study as well that kind of just pulls everything together in terms of getting patients cleared for their sport. So a lot of these things we've already talked about, so I will just quickly kind of run through these. But again, we're looking at clinical signs on the left. So no functional instability episodes as our patients have gone through return to sport tasks. They're doing dynamic movements, they're doing single leg movements. Are they having any sort of instability, which would lead us to believe that there's something going on with their ACL? If that's no, then awesome, we can move forward, right? So no effusion or swelling, full range of motion, and then pain-free in their tasks that mimic their goal. Everybody's goals are different. Are we able to go through and complete tasks that mimic what they want to get back to? And are we having pain or dysfunction with those tasks? If no, great. We can look at neuromuscular control. So having a limb symmetry index on a single leg sit to stand test, greater than 95%, having a symmetry of greater than 95% on our isokinetic quad and hamstring strength, having limb symmetry index of greater than 95% on hop test battery. This can be horizontal hop testing as well as vertical hop testing. And then again, assessing movement quality during videotape, single leg hopping and jumping variations. Patients are going to establish compensations to work around their deficits, right? So we want to make sure that these movements are as normal as possible compared to their other side to avoid any sort of complications as they get back to their sport. So making sure that these movement qualities are normalized. So this is where the coach's eye, this subjective piece comes in from a clinician standpoint or a coach's standpoint. And then again, also looking at movement quality during videotaped field training. So getting them actually back to, whether it's field or the court, getting them back to sport-specific movements, videotaping that and seeing, are we jumping? Do jumps look normal? Do landings look normal? Are they accelerating normally? Are they decelerating normally? Are they able to cut normally off both sides? Are all of these things normalized back to what they should be so they can get back and play without having to think, right? And then looking at the psychological component, are they confident in their tasks that mimic their goal? So that's what we're looking at, the ACL RSI, the PD IKDC, and then are we able to measure that? And then are we able to measure that and then also quantify how ready our athletes are by having them provide us with the information that lets us know how they feel or how they perceive themselves and their confidence as they get back to their respective sports. So all of this encompassing a very long and muddy at times, but very in-depth return to sport process, starting from day one post-op to the 9 to 12 to 15-month mark, whichever time frame your athlete is on. Just making sure that we have, set criteria in the early stages of rehab in order to progress us through to the mid stage, set criteria in that mid stage to then progress us to the late stage and sport specific, and then set criteria to get us out of the sport specific stages of rehabbing, just get them back to their sport. Whether it's objective, subjective, just ensuring that we have set objective criteria points that are going to have lasting outcomes to give our patients the best chance to be successful. And then we've got references.